Bismillahir Rahmanir Rahim, ladies and gentlemen. You are most welcome for the topic of tonight, which should be on ECG for MRCP, and we would be tackling the ECG syndromes. Those are the topics we are intending to cover. Myocardial infarction covered already, life-threatening arrhythmias already done. This time I would be covering the ECG syndromes and then followed by the supraventricular tachycardia, because most of the ECG syndromes, actually two of them, would lead to supraventricular tachycardias. So here we are, let's start. The ECG syndromes constitute different, like 3 types of syndromes, which are the most common ones. Brugada Syndrome is probably the commonest, with a prevalence of 5 in every 10,000 of the population. It's an autosomal dominant condition and usually presents with different presentations like palpitations, chest pain, night agonal respiration, and it might present for the first time, unfortunately, with sudden death. The commonest cause of death would be ventricular fibrillation, and it leads to sudden cardiac death or arrhythmia leading to death. This is the ECG, which is showing ST segment elevation at the J point in V1 and V2. And this is by far the commonest way the ECG would look like. You might find saddle-shaped ST segment elevation also in Brugada 2. And there is a very important systematic review in PubMed if you'd like to review about Brugada syndrome. This is the WPW syndrome, or WolffParkinsonWhite Syndrome. It's another congenital disease with an abnormal pathway between the atria and the ventricles, leading to an abnormal circuit through which there would be re-entry and propagation of the cardiac impulse, leading to supraventricular tachycardia. Those are usually young patients. Their age is usually between 20 to 30 years old, and they may have other structural heart diseases such as cardiomyopathies, particularly hypertrophic obstructive cardiomyopathy, Ebstein's anomaly, and other types of cardiomyopathies. Their main presentation is palpitations. They might have panic attacks, sweating, pallor. They might have dizzy spells with brief loss of consciousness as well. And it's important to rule out thyrotoxicosis in any patient with tachycardia. Those patients usually might have normal ECG by the time they reach the emergency rooms. That's why it's very important in such complaints to go ahead and do Holter monitor and even electrophysiological studies, because the electrophysiological study leads not only to the diagnosis, but it also plays a role in therapeutic, as a therapeutic tool for the ablation. This is the ECG. It's showing the short PR interval, the delta wave just at the start of the QRS complex, which is a bit widened. So wide QRS complex, delta wave, and short PR interval, the triad which forms the WolffParkinsonWhite Syndrome. There is also another syndrome known as Lewin syndrome, and this is just like the WPW syndrome, except for the fact that the QRS complexes are normal and there is no delta wave. So just you would find a short PR interval. This is the ECG, which is showing short PR interval, but no delta wave, no wide QRS complexes. By this, we would come to the end of this mini lecture, and up next would be the supraventricular tachycardias. Thank you very much, and looking forward to meet with you in the next lecture. Thank you.